Hello, everyone, and welcome to today's webinar. This webinar is brought to you by the Global Health Data Science Hub in the Global Health Network, University of Oxford. The topic of today's webinar is Ethics of Data Science in Global Health Research, Regional Case Studies and Practical Example. My name is Julio Canario. I am the founder of Fundación Etikos in the Dominican Republic. So thank you for joining us, and we are just about to start. And before that, some housekeeping. Firstly, this section is being recorded. The recording will be shared in the coming days on the Global Health Network platform, so you can review materials and share. These materials can be found using the link that's just being shared in the chat box. So you can find the chat box at the bottom of your Zoom. And you can interact using this function, which is the chat function and the Q&A function. You can interact with us, with the panel, and you can find this tool in your bio. If you have any technical issues, please let us know in the chat, and the Global Health Network team will aim to assist you. If you would like to ask any question verbally, please raise your hand during the Q&A, but we encourage you to use the Q&A box. So we have a dedicated time allocated for Q&A questions, so you will try to get through as many questions as possible. But if you don't have time for all of your questions, we will save them for trying to share them after with the recording. We are happy to see all of you just sharing your names, your institutions with that using the chat function. We are happy to see all the engagement already from UK, from Uganda, from all over the world. So due to the number of participants that we have over here, your camera and your microphone have been disabled. But please feel free to use the chat box whenever you can. So also I would like to share with you the agenda and to share with you some of the things that we are going to do today. We are going to have an introduction to ethics of data science in global health research, discussing a brief story of the global health research, ethical issues arising in global health research, in those related to data collection and sharing. Also, something very important is to propose solutions to ethical implications of how this relates to global health network and partners work. Also, we will discuss some ethical issues arising in academia, social media platforms, how this platform could facilitate scholarly work, scholarly communication, and also the distortions and bias in algorithm mediation, how the English and language publications have favored over other languages in recommendations system. And we always are going to have some quick discussions and questions. At the same time, some examples from the regions, example from Latin America, the Caribbean, ethics committees versus researchers, understanding the ethical nuances of data management and health research, and some examples from Africa as well, and from Asia. So we are here our panelists, and I am delighted to present them to you. We are going to have with us Asna Opal. She's a PhD student at the Global Health Network, University of Oxford, United Kingdom. We are also going to have as a speaker Luciana Monteiro Krebs, data curator at the Fiocruz Foundation, and she also represents the TGHN in Brazil. Daniela Morelli, at the Institute for Clinical Effectiveness and Health Policy from Argentina, Anthony Afun-Ade Awa. He's a postdoctoral research fellow at the Global Health Infectious Disease Research Group, Kumasi Center for Collaborative Research in Tropical Medicine. And he's a lecturer at the Department of Molecular Medicine, the School of Medicine and Dentistry in Ghana. And also to Dr. Lalia Nahid. She's a scientist, Non Communicable Disease, Nutrition Research Division, icddr, and she's the regional lead at the Global Health Network Asia, Bangladesh. So we are very happy to share with you all the registration that we have for this webinar. As you see, we have people from all over the world, from Kenya, from India, from Uganda, Nigeria. So Africa is here represented, as well from Spain, the United States, from Cameroon, Malawi, and from many different other countries, including from Latin America as well. So the role of you that are joining this webinar includes student, lecturer, research assistants, students, data manager, PhD students, nurses, project managers, pharmacists, doctors. So we really have a very good representation for our webinar today. And we are very happy that you are here, that you make it. So let's continue commenting that we have plenty of resources for you. The recording, the materials, and the presentation is going to be shared with you at the Global Health Data Science TGHN.org webpage, and also through different web pages that you have here at the screen. And we are going to be sharing this information through our chat bots as well, and also through these web pages as I mentioned. So we are going to be a section with plenty of materials, and not only the knowledge that we are going to receive from our speakers. So let's see. We are going to start with our first presentation, our first speaker, Asna Upal. She's a first-year student at the University of Oxford. And she's part of the HDR UK Turing Welcome PhD program in health data science. As part of this program, she has been working with TGHN since April 2023. And her work has mainly related to Pathfinder projects and data science capacity building with TGHN's regional partners. A key aspect of this work that she has been doing consider the ethical perspective of data-related initiative in global health research. And before coming to Oxford, she worked as an epidemiologist at the Public Health Agency of Canada, working on COVID-19 surveillance. So welcome, Ashna, and we are happy to hear what you have to say to all of us today.
Thank you so much, Julio. Thank you for the introduction. And I'm so excited to see so many of you here today. I'm going to give an overview of this webinar's topic area in the next few minutes. Let me see. There we go. So to start us off and put any ethical notions into context, we'll first get a brief look at the history of global health. So global health is rooted in colonialism. In the 1600s and 1700s, Europeans were traveling to warmer countries that had harsher climates and new diseases. This gave rise to the field of tropical medicine, where the focus was protecting the health of the colonizers in these new climates. Fast forward a century or two, and it became widely accepted that microorganisms called pathogens or germs could affect disease, which completely changed how disease prevention occurred. Medical missions also became popular, wherein religion-driven medical services were provided in the colonies. Post-colonial global health, on the other hand, looks a little bit different. We now have multilateral organizations and NGOs like the WHO that have set global health goals and have routed funding towards achieving them. There's been an absolute explosion of global health research to better understand, prevent, and treat diseases. Yet it still remains that the areas with the greatest health burden often have the least research capacity. Indeed, there is vast inequity in where research is happening, who is leading, and who is benefiting from the evidence, particularly related to advancements in data science. Luckily, we are slowly shifting in focus to equity and justice and building research capacity in low and middle income countries, or LMICs. So let's discuss some key ethical issues arising in global health research in general, as well as some ethical issues specific to data science and the health data lifecycle, which I'll explain shortly. So while there are many ethical issues and implications that can be discussed, I've presented 4 broad categories here. The first of which is funding. So funding for global health research often comes from wealthy countries or independent organizations that try to push their own interests over what local health priorities actually are. Access to funding may also be a barrier for researchers and LMICs. The second is authorship. First and last authors on research papers, which are 2 of the most important positions in the list of authors, are often from high-income countries. So recognition and credit isn't given where it's due, and it creates a sort of academic inequity. Research publications are also most often biased towards English, which is a colonial language. Third is local capacity. This is a big one. Research set in LMICs is often transitory and does not aim to build local capacity, so interventions are often unsustainable. And finally, we have participation. Studies conducted, whether they're observational or experimental, require participation. And participation is often incentivized in some way, like participants get a free diagnostic test of some sort or a free health checkup. But is it fair that those who don't participate don't get that access to healthcare? So here we'll take a closer look at ethical issues related to data science, specifically in health research. So this diagram that you see on the screen here comes from the Global Health Network's Data Science Hub, the link to which is also on the screen, and illustrates what's called the health data lifecycle. So in other words, this diagram shows how data flows from research planning through data capture and storage, through data sharing, analysis, and finally into research outputs and impact. And there are some ethical issues that can arise at several points during this life cycle. So for example, under research planning, undertaking research for public good is an ethical obligation. As well, during data capture and storage, data collection must address the research question appropriately and be collected well to facilitate good research. Data must also be collected with informed consent. As well, infrastructure needs to exist, ideally, to support local data storage rather than data moving from low and middle income countries to high income countries during research. There are also ethical implications related to trustworthy data sharing. An important question here is who owns the data? This forms the basis for things called data sharing agreements that help protect the individuals behind the numbers. Data access and fair data access is also important to keep in mind. Namely, should data be freely available or should it only be accessible by certain people? Also, there are ethical implications related to research outputs and impact. There's an ethical obligation to share study findings, especially if it's being funded by public money. Sharing findings can also help facilitate similar research, but there are important questions like what happens when you've shared findings and then someone decides to withdraw their data. These are important to keep in mind. So now we'll briefly switch gears to discussing potential solutions to the ethical issues that we just discussed. So the ones you see on the screen here are among many solutions, and we'll see some practical examples of these faced later on in the webinar. Examples included on this slide include increasing funding allocation to better address global health priorities, promoting local healthcare jobs to combat brain drain, which is something that happens when people move countries or move to higher income settings to find jobs. We should also build emergency preparedness infrastructure for global pandemics because these tend to affect low and middle income countries the most. It's also imperative that we change the publication landscape to encourage non-English publications. We should also encourage collaborations not only between high income and low and middle income countries, but between low and middle income countries themselves. We also should create systems where data does not need to move away from the local context by building infrastructure. We should change who generates evidence and who gets recognition. And ultimately, the goal is to decolonize global health and eliminate white supremacy in the mindset of global health. So the latter half of these are things that the Global Health Network and its partners directly address through their work. But who are the Global Health Network and their partners? Global Health Network and partners are all over the world. So this map here shows an example of some of the partners represented today, either in the organization of the webinar or as a speaker, but there are many, many more key players. And together, these players strive to drive equity and build local research capacity. So the motivation behind their work is that data science skills are crucial to analyzing ever-growing amounts of health data, but there exists a global inequity in data science skills. Many recent initiatives have focused on building research capacity. However, there is still a big gap in data science skills in low and middle income countries, as progress has predominantly occurred in high income settings. So there is a need for building data science capacity and encouraging collaboration within LMICs to further advance expertise and sharing of best practices, which is why we're having a webinar like this today. We all have so much to learn from each other, and I look forward to learning from the other panelists today, and I hope you do too. So with that, I'll say thank you for listening, and I'll hand it back to Julio. Thank you.
Thank you, Ashna, for this very insightful presentation. You have brought so many issues, so many topics that we need to consider in today's webinar. We are going to follow our discussion, listening to Luciana Montero Krebs. She holds a PhD in information science and communication, a PhD in social sciences, a master's in applied linguistics, and she's also a librarian. Her latest book delves deeper into algorithm mediation in social media platforms, how data and artificial intelligence shape structures, reputations, and relationships. In a 25-year career, Luciana has accumulated research experience for internationally recognized universities, in addition to 15 years working in the information technology industry. She specializes in knowledge organization, human-computer interaction, and computational linguistics. She is currently data collector at the Fiocruz, at the Global Health Network, and at Fiocruz Official Data Repository for Research, icddr, both within the coordination of information and communication of the Vice Presidency of Education, Information and Communication of the Oswaldo Cruz Foundation. Welcome, Luciana, and we are looking forward to hearing to you.
Thank you, Julio, and thank you all for attending. I'm thrilled to be here. And while the previous talk noted ethical issues in the production of research, mine relates to the ethical issues in consumption of research. And I would like to start by sharing a quote which very much inspired my latest research. A couple of years ago, in a class of human-computer interaction, I came across this quote from Mark Weiser, which reads as follows: "The most profound technologies are those that disappear. They weave themselves into the fabric of everyday life until they are indistinguishable from it." This quote from me reflects the importance of looking carefully into things that we get used to in our daily lives and that shape the ways in which we interact with each other, but that we are barely aware of how they actually work, such as the algorithms. To put this into practical terms, in the data life cycle that Ashna just showed to us, we find phases of the research process. For those tasks, it's common that we access digital platforms. For instance, we go to academic databases such as PubMed and Web of Science for consulting literature. To find open research data for reuse, platforms such as Zenodo and other data repositories are often used. And to look for researchers' profile, but also literature and data sets, we consult digital platforms known as academic social media, such as ResearchGate and Academia. All of these platforms offer recommendations of content based on algorithmic mediation. Whenever you see the words suggested to you or best matched to your search, these contents are recommended by an algorithm. So algorithmic mediation can be defined as the use of automated mechanisms to deliver personalized content to users of digital platforms. They normally involve the user's demographic info, their browsing history, the metadata of the content itself, and the behavior of similar users in the platform. The algorithm then calculates similarity between contents and users to infer how relevant a certain content can be to the user. The reflections I'll bring today rely on the results of 3 multidisciplinary research projects developed in Brazil and in Belgium, but involving platforms based in seven countries. These projects had multi-method approach, ranging from company inquiry to code inspection. In this short video, there is an example of the code inspection. I compared information from the actual code on the web page with information from several sources, such as the interface and the patent of the digital platform, to then investigate the impact of technical decisions on research as a whole. And here are some of the reflections I would like to share with you today. The case study with academic social media platform showed that almost all the content in the platform is algorithmically mediated. This goes for researchers to follow, papers to read, jobs to apply for, and etc. But I promise this is the most scary slide on the presentation, don't worry. But it's important because this graphic represents what appears on several pages of a digital platform in one only visualization, and also the interconnections and data behind the interface. The aim here is to show how complex the organization of content is. The main takeaway is that metadata, or data about the data, is heavily used to make guesses about what the users are interested in. And these guesses will influence 3 main things: the type of researcher that the system thinks you are, the type of content that you will see in the platform, the order in which this content will appear to you. And technically, we're talking about profiling, information selection, and information prioritization. These mechanisms in the algorithm filter what appears on the interface, but we have little control over them. And here's a good example. As for profiling, I found that 67% of the keywords used in the researcher's profile are inferred, which means that the majority of the words defining the user's interests are not informed by the user, but created by the system. These 67% are also hidden behind the interface and cannot be edited by the user. So this message on the interface saying that the user can change the profiling keywords to improve recommendations is true only for 33% of the keywords, giving the user a false sense of control. Another issue is that the scientific reputation of the authors is one of the factors that impact the recommendations, both for ranking publications and to identify candidate experts. But this inference is completely datafied, based on data exclusively from the platform. Through the experts' inference processes, authors with a higher reputation in the platform gain more attention on the feed. They are moved closer to the top of the recommendations list, which can lead to even more reads and citations, and hence higher reputation. This phenomenon is called the Matthew effect of accumulated advantage in science, found when the credit for joint work is given to the best known investigator in a field, regardless of their contribution in the project. The investigator then becomes even better known, triggering a circular process where the rich gets ever richer and the poor gets ever poorer. As for information selection, the algorithm deploys automated decision-making to select the content that will be shown to the user based on inferred relevance. Even though the user can decide on what to click, automated filtering narrows the universe of choice of the content. Research shows that when compared to search engines, social media platforms tend to exhibit more homogeneity bias. Now let's look to prioritization. Digital platforms use artificial intelligence and machine learning to read and automatically index scientific literature, creating keywords to represent the topics of the publications. These keywords, along with other metadata, are used to organize the publications in a certain order, prioritizing the content. The most popular academic social media index their content exclusively in English, which means that publications written in any other idiom, regardless of the quality of the journal where they were published, will receive poorer automatic indexation. Consequently, the non-English publications will score badly in recommendation rankings, for example, lists of relevant papers to read. Another problem has to do with transparency. The General Data Protection Regulation, the GDPR, ensures the right to an explanation. And every platform user has the right to know how their data is being used to recommend content in a simple, accessible, and meaningful way. The user has the right to see, edit, download, and erase the data about them. Unfortunately, though, this is not yet reality. Investigating 43 digital platforms in different countries that use recommender algorithms to deliver general content, we found striking lack of transparency regarding the use of personal data in algorithmic mediation. Some content providers took 120 days to reply, many didn't reply at all, and others denied the use of automated decision-making, even though we found evidences of algorithmic mediation in their platforms. Some other concerns are still open questions regarding data sharing and reuse. For instance, how to protect the right of the participants to withdraw from the study after the data has been shared and reused by other research projects. We should also ask ourselves why certain academic social media platforms, which are professional networks, ask the gender of researchers. Machine learning is trained with data from the past, but if we have already huge gender gaps in some disciplines, such as less women in engineering, recommending work of men, which were majority in the past, will reinforce such gap. If you keep being shown male references, you're probably more likely to eventually cite one. In sum, today I showed that algorithmic mediation shapes the content and the interactions of researchers in digital platforms through different strategies, including profiling, selection, and prioritization of content. These mechanisms can trigger distortions and biases in scholarly communication, such as the homogeneity bias, the popularity bias, the Matthew effect, etc. The high level of inference of the user's profile can also threaten their autonomy. If the keywords that define who you are in a platform are hidden and impossible to change, and nearly 70% of them are guesses from the system, how self-directed are you? So I invite you to think about how technologies that we can barely see can impact our work and the ways we consume and disseminate research outputs. Thank you so much for your attention. Back to you, Julio.
Thank you, Luciana. Thank you very much for sharing the results from your projects. Amazing work. I am very impressed because of the insightfulness of your work. So in the chat box, you all can find the full citation of the paper. Is it there? Please go there and try to click now in this link so you can read further this work. And there are so many questions already in the Q&A box. So we plan to go to take some of them at the end of the session to discuss further. So let's continue with our next speaker, which is Daniela Morelli. She's dedicated to research and teaching. In Brazil, her country of origin, she completed her bachelor's degree in nursing and health technology in the Sao Paulo State University, and a specialty in education. In Argentina, she completed a master's degree in clinical effectiveness, among other courses, which provided her with solid foundations that serve as the basis for her to be able, from her roles, researchers. She's also an ethics committee member and mentor who joined the Global Health Network team as Global Health Research Regional Coordinator for Latin America and the Caribbean, who collaborate for the improvement of the quality of healthcare and for the construction of capacities in research, and especially for the professional strengthening of nursing personnel. So welcome, Daniela. We're more than happy to listen to you today.
Hola, gracias Julio. La verdad que Daniela para todos. Bueno, cuando fui invitada a hablar de ese webinar,
to speak, I was thinking which was the challenge in 10 minutes to convey something that is useful for you and that would help you to have less problems that I had to face when I started to work with research. So I believe that one thing that is very important to me, the data analysis, that we have a database to work with it, numbers. I am a social scientist, so I deal with words, but I know about the cases and technology. The first thing that I wanted to share with you is a process. It's about of process, including data collection, analysis. We cannot forget that this data contain information about a person. And when we focus on that, it's easier to understand why we have to comply with so many steps in our work. In addition, in the process, we don't only have the subjects, we'll also have other authors that each one of them, of their players, we have to understand their responsibility of these players. Member of the ethical committee, member of the monitoring committee, the research team, also who is going to make the decisions with the studies that we conduct, and the population, the population that we want to improve with our study. So I believe that one of the very important things, the first topic that I wanted to share with you is precisely that we don't have to lose sight of the processes, analysis, technology, that this process involves people, subjects. They are the players that are participating in the process. And thinking about that in this presentation, I recalled there is can throw a stone who sometimes didn't think or said something that wasn't. Why do I have to ask for authorization for this? Why do I have to ask for that? Why do I have to ask to share data to a colleague or a similar work, whatever? So this is a barrier that we find. These people exist to make our lives difficult. They demand more and more processes. And we have to be in the shoes of the researcher in this case. He receives the pressure of the academy, of a publication, of preparing a proposal for a release. And sometimes we have to think on the other side, the group of people that for us is a committee, and that for us is sometimes we cannot be with them. We cannot many times identify why people is so rigorous. First of all, we have to understand that within the perspective of the committee, they have the legal responsibility of enforcing the rights. We know about ethics, but they have to guarantee that in addition to knowing about ethics, they have to enforce it. until the moment the results are shown. The patient has rights on their own information on him. The data do not belong to the professional, they belong to the person. So that's why I was telling to you not to lose sight of the people that we have before us. The discussion on is who is in charge of the data, and see the researchers who will question those data can also use this data about the patient. And what was very helpful for me, the second topic that helped me a lot, when I could understand that one thing was to know about that, the professional of health has a lot of knowledge. We do the courses that we need, the practice that we need, but we have to understand how it is the process to that we must follow. They don't, sometimes we complain that they understand our proposal, but these people, these members of groups that are the people within a multidisciplinary group, when I'm writing a proposal, I'm going to be seen by the health professional, law professionals who will also have a look at it, the participant of the community that many times they don't know what I'm speaking about, but they also follow the study. Within the process of approval, I have to comply with several demands. And in addition to the question, if I as a professional, do I have to know them? Yes, I do. So it is not enough to say many things. We can send a proposal and say that I will provide all the requirements regarding the law, the person. I have to say it in a methodological way in my study and assure that I will enforce what I'm saying, what I am promising. I say that the data will be anonymous. That's enough. In fact, in addition to saying that I'm going to anonymize the data, that I have to explain how I will do it, how I will anonymize the data, because processes have to be understood by people. Not only saying what I'm going to do, you how I'm going to do it. This is an obligation within the process to cooperate without that information and know the procedures, the committee procedures. And the third topic is I have to present my work to the committee in my area, my study. And each committee has a procedure. They have to comply with the legislation in force, the international norms, the local norms. Each committee has an in-house procedure, and they are not the same. I work in Argentina, Buenos Aires. I have centers in the province of Buenos Aires, within the state of Buenos Aires. The city of Buenos Aires is autonomous. So I have a committee which is centralized in the city and another one in the province. When I have to present my study, comprising people from both areas, I have to present my proposal in both areas. This responds to the internal procedure. So I have to know how they work. Each one of them works to save time and avoid headaches. So the third topic would be, please know the ethical procedures with which you will have to work. You have to go to the committee and ask them. I recall from my experience that I saved a lot of time making questions to the ethical committee before presenting the proposal. And this is a demonstration. Please explain to me what I don't understand and ask them for replies. And after the consultation I made, knowing the operational system they have, the committee itself may improve their procedures, and also when they don't have direct responses, they can look for responses in the upper authorities of the area in order to look for responses. It is very, very important, and I share with you that for me, these three topics were very, very helpful to save time, as I said, and also to go to the ethical committee that in many times could mean a barrier to understand that many times each consultation, each question that the ethical committee asked to me helped to improve the quality of my work, and understand that the ethical approval doesn't finish when I got the number of approval. The ethical process, the conduction of the study, and the publication of results. How do I share them? But what I could learn, and I continue to learn now, is that not to lose sight of the patient. They are persons. It doesn't matter if it is a complex study or a clinical essay. At any time, I cannot lose sight of the person that has the rights on their data and look for the means to use them in a secure way with authorization, knowledge regarding the owner of the data, understanding the internal processes where they have to work, and to communicate with the ethical committee, because that committee is more than a barrier, can be very helpful to improve my study. So in these 10 minutes, these three topics could be useful for you to have a better path in your research work. I am very happy, and I am open to the question you may pose. Thank you very much.
Excelente, Daniela. Muchas gracias
for your excellent expose.
excelente exposición.
Gracias, gracias.
Thank you, Daniela, for your presentation. Very insightful regarding the difficulties that we have using different hats. Sometimes we are researchers, but at the same time, we can be seated as a member of the ethics review committee. And those are different views of the same issue. And we really appreciate that you are very clear presenting these different views and how we can reconcile those views, putting the attention mostly in the participants, in the person, which is the one that we want to protect. Thank you, Daniela. We are going to continue with our next speaker, which is Dr. Anthony Afon Ajay Awa. He's a scientific officer with the African Research Network for Neglected Tropical Diseases. He's an affiliate member of the Africa Academy of Arts and Sciences and a member of the African Coalition for Epidemic Research Response and Training, ALERT. Anthony is an early career researcher with experience in clinical research, outbreak response research, and community-based studies. As part of outbreak pandemic response research, he's part of a team responsible for the design, planning, and implementation of ongoing studies in Ghana, including the SEDOM-MARF, SEDOM-DEM, and SEDOM-COV studies. Anthony's research also includes clinical studies. He's a co-investigator for a number of observational and therapeutic trials, including vaccines, drugs for COVID-19, including the CCP study, the anti-COV, DAT recovery trials. He's a former WHO TDR clinical research and Development Fellow, and is a steering committee member for the WHO-TGHN Africa General Training Center. Thank you, Anthony, for being here with us and for being open to share all your knowledge, and we are looking forward to hear from you. Anthony, please unmute.
Thank you very much. I am happy to join you guys all the way from Kumasi in Ghana. I am a member of the Global Health and Infectious Diseases Research Group, through where most of our research is conducted. Today, I will share with you some of the ethical challenges that come with epidemic and pandemic biological sampling at the community level. This is a very sensitive topic because we know from the experiences of other outbreaks that this has often been exploited, and instead of contributing positively to research, it has rather allowed communities who live in these low middle income countries to develop a very different perspective. I hope to share our experience with you with how we conducted our research in the community and some of the steps that we took in place to ensure that we are able to comply with all ethical and GCP guidelines at the same time. So oftentimes when we consider ethics that comes with studies, the first thing that comes to our mind will be informed consent process. You need to talk to the participant about what the study is about and make sure that they agree to the study and sign the consent forms. But there's more to just the consent process or ethics than just the consent process. And one, investigators really have to make sure that they avoid wastage of samples. And sometimes because samples are available, they take more samples than they need. You can have investigators who may not necessarily take very good care of samples. They do not maintain cold chain. They will typically do what is convenient for them. And in the process, this can be considered unethical because in as much as the study participant has consented to be part of the study, the investigator may not be making judicious use of the samples. Now, of course, this brings to the point that the samples has to be put to good use. If you know that you don't have a reliable freezer to put your samples in, make sure you get one or have a backup plan to make sure that these samples are really put to good use. Your samples must be protected. If you are taking samples from communities that are very far from your research lab, you have to find a way of making sure that these samples are transported appropriately. And when you have to biobank these samples, you have to make sure that these samples are well protected. You have a backup generator, you have a backup source. You can consider putting the samples in liquid nitrogen tank with liquid nitrogen instead of a freezer if you don't have electricity. Anything the investigator needs to do to make sure that these samples are protected, they have to do that. Now you also have to make sure that it makes sense to the people who are donating the samples to your research. When you are dealing with developing economies, there are very strong religious and political beliefs. Sometimes there are a lot of conspiracy theories. And these can be as a result of the research and the purpose of the study not being properly interpreted to the participant by the field worker. The investigators are good at what they do. The co-investigators know exactly what they're doing. The study management team understand this. But when your field workers do not communicate appropriately to the participant, you may have issues there. Now you need to show working. Any person who is not part of the study, any regulator who comes to inspect what you're doing, any funder or any monitor who wants to see what was done, should be able to redraw what happened based on the documentation. So everything you do have to be appropriately documented. There has to be an SSP, there has to be an SOP, there have to be logs that any person can trace to know what happened at any point in time. And we have to make sure that we take what is needed. During the COVID-19, we heard news about investigators from all over who were taking samples just in case. We have to, as investigators, avoid the just in case sample taking. The samples are available, let us take them, then we go figure out what we want to do with them later, and we do that. You really have to avoid that simply because the samples are available. You have to take what is enough for your study. If you need 2 mils of blood, please take 2 mils of blood. Don't go crazy for 30 mils because you want to buy blood. Now, the integrity of the sample handling has to be protected. Who is handling the samples? Does it have to be in cold chain? Is it documented? Are we tracking the temperature? And we also have to figure out how to give feedback. Feedback to regulators and ethics committee, feedback to the communities we took the samples from, feedback to other stakeholders who are involved, and especially the participants where it is applicable. In our study, for example, we're interested in determining the seroprevalence of SARS-CoV-2 infection in 3 different cities in Ghana. The Accra to represent the southern part of Ghana, Kumasi for the middle part of Ghana, and Tamale for the northern part of Ghana. And we implemented a household cross-sectional seroprevalence study using 2-stage cluster sampling in these communities to do this. Now, our approach to this was very simple. We go to the community, we speak to them about the study and what it's about, take samples from these willing participants, and we will take them to a central lab in the city to process the samples, biobank the samples. Then we will transport these samples all the way to our lab, which was about more than 400 kilometers from where we were recruiting. Then when we get to the lab, we will do further investigations in the lab. Some of the challenges that we identified even before we went to the field was that you have to redefine community entry and stakeholder engagement. And so it is easier to take sample from participants who are sick, who are in the hospital. And so if you're doing a clinical research, it is easier in our experience to tell the patients that we think you have this condition, we are doing research on this situation, we'd be happy to take some samples from you and to do A, B, and C. But walking to a community, walking to people's home, talking to them and asking them for blood really seems suspicious where I come from. And so in doing that in urban areas, where people are separated far apart and you can't use the conventional community engagement tools, you have to make sure that you're able to devise means of making sure the people who are involved are aware and understand why you're doing what you're doing. You have to redefine what goes into feedback. In our case, I'll share with you how we did that. We have to redefine how you will manage perception. You have to accept that there is conspiracy theories. You have to accept that people's perception about research is not what we know. And so you have to go into the communities with this mindset, and it will guide you to engage them appropriately. You have to make sure that you are able to demonstrate accountability, reasonable doubt, and verification. If anybody has doubt, they should be able to verify the information you're giving them and what you're doing. You have to be able to also demonstrate credibility without appearing to induce people to do what otherwise they would not be willing to. And you also have to make sure that in as much as you want to implement a GCP compliant study, that you're also able to be traditionally sensitive, culturally sensitive to situations that happen in a lot of homes. Now, we use an app to be able to drop the pin and identify based on the household we wanted to sample per suburb in these cities. And this made it very easy for us to spend less time in the community, moving from one household to another with a cool box and syringe and a lab coat. And so before we go to the community, we've already identified which household we're going to enter. It also allows us to be able to document why we were able to recruit or otherwise. Now, one of the things we did was to make sure that we recruited staff who were experienced in field work and were able to engage the communities. And we provided adequate training, especially study-specific training on which procedures were appropriate. We documented everything they're supposed to do, how they approach the participant, how they deliver the information, in which tone they do this, to make sure that we reduce as much as possible any negative interactions with the study participants. We also provided guidelines on what the field workers are supposed to do and the entire study team at every point in time, including logs to document what happens, GPS locations for where these samples were taken in which households. We also had independent teams from within our teams who were monitoring the field workers at any point in time to make sure that they are doing what they were trained for in a manner that is acceptable to the community, but respecting all ethical guidelines. Now, we had to make sure that in homes where there's the head of the home, you have to seek the consent of the person who is the head of the home, even before seeking the consent of the study participant. This way, you are able to respect the cultural norms of every household, at the same time, entrenching the ethical principle of autonomy. How did we implement this study? We did this by first informing all the key stakeholders who were involved in this study in the respective cities. So we are talking about the regional government representative, the health directorate at the district and the region. And we went to the communities with institutionally branded vehicles and T-shirts from the study team. It reduces suspicion and allows people to confidently ask important questions or share their concerns with the whole approach. We also shared ID cards that verify who we were and contact details for them to follow up with us and also with the ethics committee involved. I share with you an example of a report we gave to the individuals. And so for people who chose to participate in our study, we did not share the high-level summary of the results that we found, but we gave individual feedback. In this case, we left a contact number of a clinician who they could call for further explanation if they did not understand this. And the clinician was on standby to answer these questions in the local language and in English, depending on what they prefer. We were also able to maintain the anonymity of these participants who contributed to our study by using several levels of IDs. And so team members who were not required to know the identity of the study participant did not have to know about this. The co-investigator, the data manager, and the PI of the study had access to this information so that we could prepare the reports and give the feedback to the study participant. We had some very interesting challenges that I wanted to share with you, despite what we put in place to make sure that this never really happened. The first was that people have misconceptions about what research is about and what we do with the blood. Of course, people thought that we would do rituals with the blood. Others truly believe that the government were trying to wipe them out. It's a white man's disease. They do not believe in COVID or the disease whatsoever. And so consenting to be part of the study was a bit challenging. And of course, you cannot force them or cajole them to do this. Another challenge we had was not just dealing with uneducated folks, but semi-educated folks. And they're the ones that will really spread conspiracy and theories that are false. And so we had to thoroughly engage with them and try our best on our part to make sure that every available information is being given to them. And especially they are empowered by knowing that they can report us to the regulators and seek further questions if they think that anything we are doing is suspicious. Another problem we had is that you can have the head of the household consenting to the study and a member of the household deciding not to be part of the study. The reverse is also true, where in some cases you can have a member of the study who's really interested, they're of legal age, but because they still live with their parents disagree and they have to comply with the directives from their parents. And this was very difficult to navigate. We had to make sure that in as much as somebody is willing to be part of our study, we trying to make the world a better place through research does not create problems in homes and disrespect the cultures people uphold. Now, we also have personal beliefs that got in the way of the work that we were doing. At some point, people were fasting, members of the Islamic communities who were fasting would not donate blood to our study. And people who, for various reasons, religious reasons, do not believe in bloodletting, or sometimes for political reasons, they are in opposition and they believe this is related to something the current government is doing and they want the government to be very unpopular. And so, you know, we just caught a stray bullet in these things, and it does affect. And you have to figure out how best, whilst you're in the field, to manage these well in a way that still upholds all ethical considerations. Now, one other thing was that quite a lot of folks were afraid of needles. It is easier for somebody who's afraid of needle, but sick in the hospital to receive a needle injection for drawing of blood or medication than for somebody who is very comfortable at home, watching a nice movie, to just donate blood to you and go through all that pain. Now, in as much as we explained the concept of what we were doing to people in a language they understood, the whole process of what we were doing was still very alien to them, and for some of them, it did not make sense to them at all. Now, I have a couple of stories to share with you in the next 2 minutes, which you find very interesting. The first was that we were arrested by the military. There's a military base in the city of Kumasi, and in as much as we had all approvals to conduct the study, the military disagreed because we were civilians, and they expected us to go through extra administrative processes that were not a requirement for our study, but would have made our lives easier. And so they arrested the entire study team, and including the vehicle that was in the field to do the study. And so I had to go to the northern headquarters to bail our study team and explain to the commander what we were doing, and reach out to them. And so it was a complete misunderstanding, and these things may happen because they found our team in the military base, and they, got suspicious. And even though they explained themselves and provided all the evidence, it was until after I went to the headquarters, produced my ID card, and explained and invited them over to our lab to see the work we were doing in COVID, that they released the team, and we hit it off on a good note and maintained a very good relationship with the military because of that. There was an individual who called the police to complain about suspicious behavior. And when we received the call from the police, we explained what we do to them, and we produce the consent forms and the approvals and the necessary documentation. It so happens that this individual was recruited on our study, agreed to participate in our study, donated blood for us, and a couple of days later changed their mind and went to report us to the police. And so the individual opted to withdraw from the study. We discarded the samples in compliance with ethical guidelines, and we explained ourselves to the police. And so we did not have the police storm up our lab or have us arrested or any of the field workers arrested. It was a very easy thing for us to disperse, simply because we took the time to provide any additional or needed information on the participant information leaflet, and also provide adequate contact details for feedback with us and also with the ethics committee. We had a case where a mother was upset with the daughter for participating in the study and donating blood. And the mother reacted quite harshly in a way that it was almost impossible for us to intervene because it was a family affair, but we felt responsible for putting the child, or rather not a child, it was an 18-year-old into the situation for choosing to participate in our study. And so one other story we encountered was, there was a PhD student, our team went to their home to recruit them, and this PhD student had so many questions, but they wanted to just demonstrate that they know what they are talking about, and it became unusually difficult. And so we were informed, we rushed to the house, and we introduced ourselves and what we do, and immediately they got to know who we are and how we are affiliated. They calmed down to engage with us, and actually also provided additional support for our study. I share with you some photos here from our study team in Kumasi, in Tamale, and in Accra, where the study was conducted. And you see here the institutional branded vehicles that were used. And so we like to encourage investigators that as much as we like to focus on the science and make sure that we follow through with our protocol, there will be things that are not captured in your protocol that you have to consider based on your certains to allow you to be able to implement your study while following all ethical compliance. Sometimes it can be as simple as making sure that you have the necessary ice packs available. Sometimes it can be something straightforward as choosing to fly the samples from one city to another instead of going about 11 hours by road to the central lab. Sometimes it can be finding an intermediate lab to process the samples before transporting it to your lab to do further analysis. I'll be happy to answer further questions that anybody may have in the audience, but I think that I bring my presentation to an end, and thank you very much for the time.
Thank you, Anthony. Great presentation. So there are so many participants congratulating the events, congratulating all. And you, Anthony, you have mentioned so many key aspects. Wow. Regarding data collection during epidemics and outbreaks. even including the rest of the study team. Most of the time, we talk about the rest of participants, which is the most important ethical aspect of any research. But you also mentioned some very interesting experiences in your work, and even including the critical aspects of the risks of our team members, which is we shouldn't exclude when we are talking about ethics. We should have this broad vision covering every aspect. So we have Asna, she started setting the tone of this conversation. Then we have Luciana with a very interesting things and topics regarding things that we don't manage a lot, which is algorithms and how this impact science. And then Daniela brought a huge topic, which is ethics committees in this regard. So thank you, Anthony. And many people are asking about the documentation, the materials. All of them are going to be available through the webpage at TGHN. So don't worry. The team is always putting at the chat box the information. Please go there, try to identify the chat box at the bottom of the Zoom, and you will find it. And we are close, not to the end, to start our discussion. Before that, we need to hear our Dr. Aliyah Nahid. She's a great speaker. Her research career started in 1994 in icddr and has spanned several topics, including communicable diseases, non-communicable diseases, and health systems research. Dr. Nahid has been awarded in Bangladesh Academy of Science, Sultan Hamid Kathuri Science and Technology Gold Medal for her commendable contributions in scientific research in Bangladesh. And she's a fellow of the Bangladesh Academy of Science. And she has been the principal investigator of numerous research projects and has published more than 100 publications in peer-reviewed journals. She has served the Ethical Review Committee of the icddr for 6 years, and currently she serves as a member of the National Research Ethics Committee of Bangladesh Medical Research Council. Dr. Nahid has served as a panel member of many committees, including the UKRI, the Global Effort on COVID-19, GECO, and the NIHR Global Health Units. She is the associate editor for Frontiers in Public Mental Health. So please, with that, welcome to Dr. Nahid. We are happy to listen to you today.
Thank you, Julio. This is very kind of you. And to be very honest, Anthony created the background for me to start my presentation. So thank you again for inviting me as a panelist and are requesting me to share my experience. So I'm going to share my slide first. So this is not, I'll not talk about research here, but I will talk about a story, what this research actually led up to, and what are the ethical issues after this ends. So I'm just checking whether you are seeing my slide. You can see my slide, Ashna?
Yes, Doctor.
Excellent. Excellent. So the example I will actually share with you is probably not very different from many due to the between infectious disease and non-communicable disease research. So I'm going to talk about a case story in Bangladesh. Bangladesh is experiences emergence of non-communicable disease over the last 5 decades. And currently, of all deaths, more than 60% deaths are attributed to non-communicable diseases. And of them, cardiovascular disease and particularly myocardial infarction and cardiovascular stroke are the more common for deaths. But one of the contributor is hypertension, and a little reduction of hypertension of 2 millimeters of mercury of blood pressure actually can reduce this risk that has been already evident. And if we look at this data, so in the latest data suggests that nationwide hypertension prevalence is very high. Out of every 1 of 3 to 4 people, someone is suffering from hypertension that requires treatment, and more than 66% are not having control of it. That means they are always at a risk of having a stroke or myocardial infarction, that means heart attack. So a group of researchers in Bangladesh joined researchers from Pakistan and Singapore and Sri Lanka to devise a nice intervention to be built into the primary care system of these 3 countries. And they wanted to look at the cost effectiveness of this multi-component intervention to control hypertension. So it is famously known as COBRA BPS, that is not a snake, but control of blood pressure risk attenuation in Bangladesh, Pakistan, Sri Lanka. This study actually included 10 villages from each country in Bangladesh. 2 districts are selected to identify 10 villages. So it was a stratified cluster randomized controlled trials among individuals 40 years or older who already has been diagnosed as having hypertension and provided informed voluntary consent. So these clusters were divided into intervention group where the people get comprehensive hypertension care, that is a standard care that recommended by global guidelines, and other groups were, into comparison, they use usual care practice in the country. So the study ran for 2 years and then it was evaluated. For this study, all aspects of principles of research ethics were followed. Firstly, the respect for autonomy. So response and the participation from both of the participants, any participant was very carefully identified that they participated on their self-will. And all efforts were made so that this is like a service in a routine care. So no extraordinary things are being done that can be considered as a harm. And it was ensured that benefit outweighs the risk if there is any. But the final idea is that this research offered justice to the community where hypertension care was not available in the routine health primary care system at that moment. So what were the interventions? Very simple. That the government health workers were actually trained in the intervention villages and what is hypertension. And they were trained how to help the families who had hypertension actually reduce the risk factors, like by improving lifestyle modification. So they conducted these sessions every 3 months at the patient's home, not for the patient alone, but along with other family members so that the patient can get support from the family as a whole. The second major thing was that these healthcare worker, who is a government staff, she actually measured blood pressure following a standard method, and anybody having uncontrolled blood pressure or seems to be having difficulty were referred to the nearby district hospital for additional care. And in that hospital, the doctors were trained how to treat hypertension following an algorithm-based case management. And these study teams actually negotiated with the government of Bangladesh to ensure supplies of adequate antihypertensive medicines for the hypertensive patients so that they don't have to pay from their pocket for the drugs, which was not available at that time, and they don't become poor just because for participation in the study. So there were other aspects like people were offered support for coming to the doctor for checkup from home if they're poor and didn't have money to spend for their vehicle. But while this was implemented in the health systems, it did some good things. The healthcare workers who never knew what is hypertension and measured blood pressure, they actually could know that what is the role of measuring blood pressure. They continued that effort of educating the families, and the doctors continued to practicing these guidelines for treating hypertensive patients. And ultimately, this helped also the government to learn what should be done in the future. And through the whole process, the respect of autonomy, protecting the autonomy of the people, treating them with courtesy, not only the patient, but also the care provider, they were all at the part of this research. And there is complete disclosure, what is the interest of the research, and they were informed properly so that they were allowed to give consent voluntarily, understanding the whole aspect on self-will. And although the risk was really minimal, but it was clearly mentioned that because the blood sample collections were done and physical examination was done. So all these things and how referral needs to be done, and you may have to spend some money from your pocket if need to, and what a potential, everything was provided for complete information. But on top of that, although this algorithm-based case management was standard globally, but it was not available in Bangladesh at that time. So it was an additional benefit that when these patients were going to the service centers, they were getting thorough checkup and they were getting treatment for free, and also the drug supplies for free, like including lipid lowering drug. That government doctors and managers actually made this happen for supporting the study, which is phenomenal. And that standard of care, of course, was higher than the care practice available at that time in Bangladesh. But at that time, we collected data from both the service area where interventions were being provided, and also from the usual care area where only the usual care practices are available. This additional enforcement of treatment was not imposed. But for data collection, you have to collect everything, about the practice, what are their medication adherence, if there is any difficulty happen or health issues, all were collected in both groups. But the patients who were in the intervention group were told that this is a research, and under this research we are providing this service. This may or may not be available otherwise. Anyway, so the whole idea was to empower the patients to make the decision and have the right not to participate if they're not willing, or help them or empower them enough to withdraw from the study even after participation. So it was ensured. So decision is voluntary in terms of giving data, sample, physical examination allowance, and consent was not obtained just once. It was obtained multiple times. For every visit, they were asked if they want to continue or want to withdraw. And so there are multiple consent as well. So you can imagine. So there is all kind of efforts offered to make sure that it was a very high ethical integrated study. But there's a question, that question came from the research team itself. While these services are not available in these facilities, and these treatments are, poor people cannot afford treatment, and those are available free for cost, is it a question? Is it inducement? That is, automatically people are not empowered to withdraw because this care is not available, but I leave this debate for you to raise in the future. So what is the role of the researchers? In the beginning, they identified the research need for something that never was available. So they did the right ethical decision to conduct the research, but they had to go through the entire research cycle, that what a standard research team would do, and they have done it. And they actually conducted data collection in a very ethical way, including only valid data, not extraordinary data. And the final obligation was to disseminate these findings and to publish a manuscript, which is, in one hand, it is very ethical thing to publish, because otherwise no one would know a good study had happened or what study had happened and what was the outcome of the study, whether it's good and bad, if that can be adopted by others. And of course, it was the academic interest of the researchers to be published. And the result was phenomenal. So just in 2 years, the systolic and diastolic blood pressure, it decreased and significantly in the intervention group compared to the usual care group. And this phenomenon was observed not only in one country, in Bangladesh, but all 3 countries. So it was taken for granted. It is a fantastic implementation research that showed that a normal service delivery system strengthened with hypertension care using this multi-component model is feasible in this country. So the researchers published is one of the top-notch journal in the world. And not only then, they also analyzed the data to show that this is not only excellent model for service delivery to reduce hypertension, but it is also available at a very low cost. So naturally, the next step would be to offer this service to the community, as those who were not involved in the research and beyond the community. So everybody benefits from this. This is why we do research. But what happened? This was only bestowed upon the researchers to complete the study, but the benefit to go beyond the research is not always limited to researchers' ability. It is always limited in researchers' ability. So it should be the system, the government, the stakeholder they need to pick up. What happened? When the research was taking place, we collected a lot of data, and those data helped us to understand what is the problem and what should be the solution. And the solutions were identified and implemented, and we have seen an extraordinary result. But that is only for the period of the research. So is it ethical to stop data collection and then let the community go on their own and let the providers become helpless and go back to their usual practice where it is not a standard of care? So how we can get out of this? So even a very ethically conducted study cannot offer justice. So we are talking about justice of collecting so much of data, publishing so much of information. So what next? There is a big thing. Data were only collected for research. It was not integrated into the healthcare system. So the kind of research that this group did was a preventive model. If you look at the left-hand side, so it is a preventive model. So if someone is having an early stage hypertension that's treated, they can avoid risk of danger and fatality. But if this program is not integrated in the holistic care model, and the routine care, so we do not get the benefit after the research is over. So data should be integrated in the holistic healthcare system so that it can be reusable by the local practitioners to make the local decision. Because researchers will not be there, they will leave one day. So what will happen to the patients? What will happen to the provider? They were trained to treat this patient with good care. That is why it is really important when we conduct a research on non-communicable disease, conducting a fantastic high quality research is not enough. You have to think about how this data can be integrated in healthcare setting so that real-time analysis can be done by the healthcare providers to make the real decision for rapid response to healthcare. And why, what I'm saying, it is proven because of COVID pandemic. This study was conducted just right before COVID, and the COVID came, and there's no system. And for the 2-3 years, these people were completely avoid of treatment of hypertension care. We don't know what happened to those patients, but is this ethical conduct of a research which is beyond the ability of the researchers? So it is my last message, a take-home message, that we really need to consider data capture is a very important tool, but we need to use this data in an ethical way, not only for the research only, but also bringing the benefit to the community who participated in the research, because only data and data only can support real-time solution for a lifetime condition, and non-communicable disease is a lifetime condition. And in order to do that, we need to have trained healthcare providers who would collect routine data in their routine system, and they have the ability to conduct a real-time analysis to identify the problem and come up with real solution. But it is the provider level, health systems level. Is that enough? Absolutely not. The community needs to be communicated that what is going on in the community and what they should do, and empowerment to community is very important to help them come forward to have their healthcare taken and prevent their conditions, the severity of the disease, and ultimately protect life. So non-communicable disease, it does not happen just at the older age. It happens starting, the risk starts from the birth and it continues for life. So if we can capture data ethically to support real-time solution for a lifetime condition in NCD, that will only impact to reduce multimorbidity. And that was the last word I want to just end with my talk. Thank you very much.
Thank you, Dr. Nahid, for your presentation. Very insightful regarding your work in Bangladesh, and it helped us to take into account the many nuances that needs to be considered when we are collecting data, when we are managing a project national scale. Thank you. Thank you. We love to listen to all this experience. So we have get to the end of our webinar. Unfortunately, we have been using the Q&A function. So many of you have been very active asking questions, and also our team and the panelists have been responding to the Q&A question very actively. So I will ask you, to all of you, to go through the Q&A box and to see and to review all the questions that have been posted and the responses as well. As you see, it is almost impossible to cover all the topics in a manner that we are satisfied. So in this 1 hour and a half, we have been covering issues regarding data collection, all the phases of the clinical epidemiological studies, and how the data should be collected, but also handled, and then used, reused. And basically, some of the questions that I love from you, Calvin Madbida, he was asking about in addressing the challenges of data sharing. What is your take on web-based data collection methods that is being favored now by high-income countries, thereby leaving countries in LMNC in a position that owning the data that is generated? So one of the key responses that I see here is to consider that each country, each institution, should develop their own data governance framework. So this is the time for us to keep analyzing, learning about these issues, and then cover them into our policies, and from policies to practice. So thank you to all of you that have dedicated part of your time for joining us. We are more than happy from this event, and you are going to be able to receive all the recording in our web page that have been shared. And thank you very much to the panelists as well. And thank you. We will now close the session and talk to you in the next webinar. Thank you.
Thank you.
Thank you. It was lovely meeting all of you. Brilliant presentations. I also have learned a lot. Take care. Good night from Bangladesh.
Nice to meet you. Thank you so much.
Nice to meet you.
Yeah, take care, everybody.
Congratulations,
Bye,
guys.
Ashna.
We're still recording, right?
I think so.
Yeah.
All right, guys. So have a good day. I'll catch up with you later.
Yeah.
Bye.
Brilliant work. Keep it up. Bye-bye.
Bye-bye.